Welcome to the Neurology Live Mind Moments podcast. Tune in to hear leaders in neurology sound off on topics that impact your clinical practice. I'm your host, Marco Meglio, editor with Neurology Live. In this episode, we sat down with Dr. Daniel Ontaneda, a staff member of the Cleveland Clinic Mellen Center for Multiple Sclerosis, who gave an in-depth overview of the newly launched McDonald Criteria for MS. Ontaneda, who also serves as an assistant professor of neurology, discussed the greatest changes to the criteria, including the incorporation of biomarkers such as central vein sign and the ability to diagnose MS before clinical symptoms arise. He also highlighted how this new criteria incorporates a different philosophical look into diagnosing multiple sclerosis, as well as some of the aspects of the criteria that may need some time to get adjusted to. Let's dive in.
One of the things that we're cognizant about as we formulated the new criteria is that, we needed to strike a balance. That is, with any diagnostic test, you can always exchange greater sensitivity for a lower specificity. And in MS, I think both are important, right? We want the criteria to be sensitive, particularly early in the disease, because it's really important to start our disease modifying treatments early, because we know they're most effective if we start them early. And on the converse side, as we're using highly effective therapies, and perhaps as the risks of these therapies are, well known to neurologists, getting the diagnosis right is more important than ever in my mind. And that's where, specificity is important. We know that approximately one in 5 patients with multiple sclerosis, approximately 20% may be misdiagnosed. And so kind of going into all these conversations, we knew that we had to balance those two factors out. On the one side, there's still significant diagnostic delay in MS. Depending on the studies, you can read up to 2 years from when a person starts out with symptoms to when they're diagnosed. And on the other side, this kind of looming number of 20% that are misdiagnosed. So I think the criteria achieve that. And I think that's what's exciting about them. And I think really the criteria are changing in a large number of ways. And I think philosophically also we're changing how we think about multiple sclerosis, which is, of course, well.
Dr. Ontaneda, can you talk a little bit about some of the actual major changes to the diagnostic criteria? For our clinical audience, what is the sort of biggest changes, and what are things that treating clinicians should be aware of?
So I think that the first thing is kind of to philosophically discuss a little bit about how the current criteria are a departure from the previous iterations of the McDonald criteria that we had. And I think for many, many years, when we made a diagnosis of MS, they were hinged to these concepts of dissemination in space and dissemination in time. And as we have developed more and more very specific imaging biomarkers, it's pretty apparent that this concept of dissemination in time is not as important. We already saw that happen early on in previous iterations of the criteria, where you could use oligoclonal bands instead of having a second clinical attack or new MRI lesions, right? So it's kind of been an evolution of that requirement to the point now where we're basically saying, if you have sufficient number of lesions in a given number of what we call the typical topographies of multiple sclerosis, you no longer need dissemination in time. That is, you can make a diagnosis of MS if a person just has lesions in sufficient number of areas that look like multiple sclerosis. So that's kind of the one big thing that's changing, right? In the past, we always said that patients needed lesions in 2 or greater topographies to make a diagnosis of MS. We've added to those topographies, so we've added the optic nerve to that topography group. And what we've said is that if you have 4 or more topographies, that's all you need, right? And that speaks to kind of how specific having lesions in all those topographies are, and there's pretty good data. Oligoclonal bands, of course, that has already been in the criteria. So if you have only 2 topographies, oligoclonal bands count. And then I think for the first time, the central vein sign makes its appearance in the diagnostic criteria, near and dear to my heart. A lot of the work that we've done over the last 10 years were used to incorporate into these new criteria. And central vein is used in a very similar way. So if you have lesions in 2 topographies, You don't need a second clinical attack. You don't need new lesions on MRI. If you have 6 central vein lesions, that's enough for somebody to call that multiple sclerosis. So I think, in my mind, that's kind of one of the big philosophical changes is kind of the non-reliance on that dissemination in time. I think the other kind of thing that, in my mind is changing quite a lot, which is kind of corollary to this, is that, we used to talk about dissemination in time and space in very specific contexts. And those contexts were classical clinical attacks, right? And so this is how relapsing-remitting patients present, or individuals who have progression of disease from onset. And those were the only 2 ways you could get into a diagnosis of MS previously. But we recognize that there are patients who have MRIs that look like multiple sclerosis. They're accumulating new lesions. We have clinical trials in that group. That's something called radiologically isolated syndrome that demonstrate that if you start disease-modifying treatments early on, you actually can, lengthen the time to when a person actually has the clinical manifestations of MS. And so all of us have kind of been, treating, many of those patients with disease-modifying medications and knowing that those people had MS, but they weren't integrated into the criteria. So the criteria the new criteria takes the important step of, us being able to call an individual who has radiologically isolated syndrome, multiple sclerosis, right? And of course, you need to meet very specific criteria for that. That is, you have to have lesions in the typical topographies 2 or more. But then you can use those same very specific biomarkers, oligoclonal bands, development of new lesions, or once again, makes another appearance, presence of the central vein sign, to call that multiple sclerosis. I think this is a big, big departure for us. And although, the data that informed this was based on radiologically isolated syndrome, that's completely atypical individuals with MS. One would expect that will also apply to individuals who don't have a clinical attack, but aren't fully asymptomatic either. That is, they're somewhere in between. These are individuals that we call as having atypical symptoms. And we think that the criteria will also apply to those individuals. So really, I think it's nice because on the one side, we're expanding when we can make the diagnosis of MS. And that really hits that sensitivity question. So what we're doing is we've incorporated very specific imaging biomarkers and, high bar to diagnose somebody who is asymptomatic with MS. But at the same time, we're expanding a whole group of new patients who can now be diagnosed with MS, which we previously couldn't. It's important because these are patients that they previously had been treating. Then there's, a couple of changes that, also relate to the fact that, patients who are in special groups, patients who are, who we know are in conditions where there can be associated, spots in the brain, individuals who are, older, individuals who have vascular risk factors. Those individuals certainly are people who you have to pay special attention to. And the criteria make mention of that mainly to reduce, the cases of misdiagnosis. Other things to kind of call out on the criteria, which I think are important, is historically we had always said that you can make a diagnosis of MS just based on clinical symptoms. And we already talked about how the biomarkers that we've developed are kind of changing, how we make a diagnosis. And now the reliance on those biomarkers are larger. And the new criteria basically state that you need some paraclinical evidence to make a diagnosis of MS, be it an MRI, be it spinal cord, spinal fluid, be it, however you can document that paraclinical evidence. And I think this is something that has brought some attention because a lot of folks have said, well, there are places where you can't get an MRI. If I can't get an MRI, if a person has metal in their body and they can't get MRIs, how do I kind of, document that? And I think the intention of the criteria is to say, if you have it available, you should do it and you should confirm it before you make a diagnosis of MS. Naturally, if you can't, you're going to have to use your best clinical judgment to make a diagnosis of MS. But I think the purpose of the criteria aren't to necessarily prescribe exactly what you do for a diagnosis. The criteria are there to help guide your clinical judgment and how you think about multiple sclerosis. So I think when you think about it in that light, it becomes a little bit more digestible.
Oh, great insight across the board. Obviously, you're always great with this stuff, Dr. Ontaneda. But one thing that kind of stuck out to me specifically was focusing in on that RIS group, which obviously, as you mentioned, we've kind of made a lot of headway over the last couple of years. Dr. Akuta's got obviously a lot of great research that's kind of advanced that area specifically. But I'm also curious from your perspective, and maybe I'm incorrect on this, but is there a chance that we may be overdiagnosing that group potentially, or is there a risk for overdiagnosing that group? Or do you feel as though that the guidelines and the new criteria very kind of explicitly lay out this group? I know because this group has been obviously a little bit more, still learning more about them over the last couple of years. So do you have any fears of overdiagnosing this group, or do you feel as though that it's not necessarily a bad thing for this group to kind of get that diagnosis and then do further follow-up? I'm just curious what your thoughts are on that group specifically.
Yeah, I mean, I think, this kind of relates to the point that we just talked about, which is, the criteria aren't intended to be, a cookie cutter, right, for everybody. It's intended to be a set of rules that helps a clinician make a diagnosis. And I think the main thing that the RIS portion of the new criteria we're trying to solve was, we have patients who we think have MS. And because they didn't have symptoms, we could not diagnose them. Now, naturally, if you take any diagnostic criteria and you don't apply them correctly, there is the risk of misdiagnosis. So understanding that, in asymptomatic individuals, it's equally important to make sure that you rule out other explanations or causes for why they might have white matter lesions. That you are sure that you meet the criteria for all the more specific biological measures that are important. In my mind, the criteria are going to allow us to make a diagnosis of MS when we think a person has multiple sclerosis. Now, you ask about the risk of misdiagnosis, and certainly, there's always going to be some rate of misdiagnosis. I think the criteria, were designed specifically to have specific markers embedded so that you can make sure. So, for example, an individual who has spots in their brain, and they don't have any symptoms, you have to rely more on the biomarkers because you can't rely on the clinical history. You have to make sure that they have oligoclonal bands. You have to make sure that they're developing no lesions that look like multiple sclerosis. You have to ensure that they have 6 positive central vein sign lesions. These are all things that don't occur outside multiple sclerosis, or are rare to occur outside multiple sclerosis, and therefore it will add that specificity that prevents misdiagnosis. But once again, the criteria cannot replace good clinical judgment. That's going to continue to be something that education and making sure that clinicians understand the criteria, understand how to apply them, and understand the biomarkers that are associated with these diagnoses.
We're going to take a quick break from our conversation with Dr. Ontaneda to keep you up to date in the latest developments in neurology. Welcome to the Neurology News Minute. Here's what you may have missed since our last episode. First, on September 24th, Amgen announced positive data from its Phase 3 MINT trial assessing inebilizumab, an FDA-approved treatment for NMOSD, in patients with generalized myasthenia gravis. Based on these new data, which show significant changes in the primary endpoint, the company is planning to initiate regulatory filing activities for inebilizumab as a potential new treatment for generalized myasthenia gravis. Days later, on September 26th, AbbVie released positive top-line data from its Phase 3 TEMPO-1 trial assessing investigational tavapadon as a monotherapy for Parkinson's disease. All told, the therapy met its primary endpoint, demonstrating a statistically significant improvement from baseline in MDS Unified Parkinson's Disease Rating Scales Parts 2 and 3 combined score at week 26. And finally, on that same day, Biogen officially terminated the rights under its collaboration and license agreement with Sage Therapeutics over SAGE-324, an investigational agent in development for essential tremor. The decision comes months after the company's reported negative top-line data from the Phase 2 CONNECT-2 study assessing the medication. For more information about these stories, head to neurologylive.com, or you can check out the corresponding link in the show notes. And now, back to our conversation with Dr. Ontaneda. Dr. Ontaneda, you obviously brought up earlier in our conversation about the incorporation of central vein signs. So talk a little bit about just the incorporation of biomarkers in general into these new clinical criteria. What do you think that they'll add to the diagnosis? And obviously, you kind of felt as though this is a long time coming. So just give your thoughts on just the incorporation of some new potential biomarkers and how they may play a factor into the diagnosis of MS.
So there's, a couple additional biomarkers which are making their appearance in the criteria for the first time. Naturally, clinicians won't be as familiar with these as perhaps, stuff they've been using from kind of when they were training. But I think there's a lot of data behind these. And, the first one that is incorporated is the central vein sign. And the central vein sign is an imaging marker that demonstrates that lesions are occurring around a vessel. And we think this is pathologically specific because it reflects that demyelination occurs around these blood vessels, right? A lot of people ask about, well, it's kind of being used, as a replacement, if you like, for dissemination in time, which actually doesn't have anything to do with time. It has everything to do with it being a specific measure of inflammatory demyelination. That is, when you see a lesion, when you see a brain where 50% or more of the lesions have veins going through the middle of those lesions, you are pretty sure that those lesions are lesions that are inflammatory demyelinating lesions. That doesn't occur to that frequency in other conditions. We've simplified the rule in order to call this, and it's something called Select 6, and we've done some work on this. And the diagnostic performance of this is really high. We demonstrated there's demonstration in two studies. One study that we conducted with the North American Imaging MS Cooperative, and one study that was conducted with a group out of the University of Nottingham in the UK, where it was clearly demonstrated that the central vein sign and abbreviated methods such as Select 6, counting 6 lesions that have a central vein on an MRI, had equal diagnostic performance or even better diagnostic performance than oligoclonal bands, which has been the test that we've historically used. And the second imaging biomarker that makes an appearance is the paramagnetic rim lesion. Paramagnetic rim lesions and central vein sign goes hand in hand because they're both based on a type of imaging called susceptibility-based imaging. Most commonly, those are detected with a sequence called SWI. That's a sequence that's used all over the world every day on MRI machines, easy to do. And while the central vein is something going through the middle of the lesion, the paramagnetic rim lesion is a small rim of iron susceptibility that occurs around the lesion. And it reflects that some of those lesions have a ring of activated microglia that also stain for iron. The iron is what makes it pop on that imaging sequence. And it's, once again, pathologically specific. Those lesions don't occur in other conditions. The specificity of pearls is even higher than the central vein. So this is a very, very specific biological marker. And how the diagnostic criteria codifies this is, the presence of one or more paramagnetic rim lesion is considered positive. And it can be used in circumstances, for example, when you only have one topography. You can use either 6 central vein lesions that are positive or one lesion with a paramagnetic rim. And I think what that reflects is the fact that the most common lesion in multiple sclerosis is the deep white matter lesion. And the deep white matter lesion is not in the diagnostic criteria. It's never been one of the topographies. And the reason for that is because it's relatively nonspecific. That is, you have deep white matter lesions because of headache or because of vascular disease, because of a variety of conditions. But if you add the central vein sign, or if you add the paramagnetic rim lesion onto those deep white matter lesions, all of a sudden, then they, of course, become specific. And so, of course, in those patients who have less than one topography, having a paramagnetic rim lesion really will be important, right? Because that's something that's very, very specific. And I think it signals, something kind of more towards a fully biomarker-based diagnosis of MS, right? We've thought for years about, simplifying the diagnosis of MS. I'm an imager, of course, and I've worked in susceptibility-based imaging. So we've kind of thought about stuff like, maybe you just need 6 central vein lesions and a rim lesion, and that's it. You can call that MS if you had the imaging techniques. So I think they're important, but I think there has to be some education done both on the radiology side of things. So the radiologist who interprets scans will have to become familiar with this. We are planning, as part of the North American Imaging and MS Cooperative, courses at the American Academy of Neurology, at the Consortium of MS Centers, at the American Society of Neuroradiology, so that we can provide some teaching on, how do you call a central vein sign positive lesion? How do you call a paramagnetic rim lesion positive? And which sequences can you do to view these? And they're, with a little bit of training, they're not that hard. So I think it's important that we kind of think also about the educational piece. Whenever you launch something new in the criteria, you need to make sure it's also backed up with some additional information. And then the last, diagnostic biomarker that kind of aids us is, the presence of OCT. So as I said before, the optic nerve now is a fifth topography, and how you demonstrate that the optic nerve is involved is in a variety of ways. You can do that on MRI, you can do that on visual evoked potential, and now you can also do that on OCT. So once again, there are also some kind of educational and technical things that we have to add into that OCT, but OCT is a tool that we use on a daily basis here at the Mellen Center. So it's only natural that now that's incorporated formally into the diagnostic criteria.
Dr. Ontaneda, always a pleasure to sit down with you. I always thank you again for taking some time out of your day. The last sort of question for you is, obviously it's great that we have brand new criteria, and I'm not saying that you guys don't need to redo them, but is there anything that you guys felt as though that you don't have enough answers to, that you couldn't put in the criteria, or still things that maybe we're still kind of figuring out in the diagnosis of MS, and that we don't want to trip anybody up or put any misinformation out there? Just curious if there was any conversations that you guys had about any of those sort of topics.
Yeah, I mean, I think one of the things that is sorely needed for MS diagnosis is some type of a blood biomarker of the disease, right? It would be great that, instead of using an MRI or having to do kind of an OCT, which takes some time, if you could just take a blood sample. Regretfully, that's not available. There just hasn't been something that has gotten to the level of diagnostic accuracy that we can use, to apply that. That's I think something that the MS field has been in search for many, many years. I'm not sure we're going to get there. But I think one of the other things that we thought about as we were putting together these diagnostic criteria is that when you make a diagnosis, it's kind of a binary, a yes or a no, and that's not necessarily how biology works, right? And so for future iterations of the criteria, I think a lot of us have been thinking about what we currently have is a table or a flow diagram, right? Which shows you, if you have clinical onset, this is what you do, this is what you do, and this arrives at a diagnosis. But the question is, how do you apply these biomarkers and how do you weight them differently depending on what, you are presented with? That is, somebody who has an optic neuritis and a transverse myelitis, you're going to have to rely relatively little on biomarkers, right? You can make that diagnosis easily. In a person who has asymptomatic MS, you're going to have to rely much more on your biomarkers, how many of the biomarkers you have. And so you start playing with all these, and it becomes somewhat complicated. It's complicated to put that into a table. So one of the things that we've been thinking about is, should we actually, instead of having a table that you can kind of follow, should we actually take more of a kind of a calculator prognostic model approach, where you input the clinical findings of the patient, you input the biomarker data you have, and you get a prediction of how likely is it that somebody might have multiple sclerosis. And that allows you to weigh things a little bit differently. That's a little bit of a pie in the sky idea, but I think it's something that we, of course, from the names perspective, have already started to work on to make, I think, diagnosis a little bit more data driven, if possible. And this has already been done in other conditions. Alzheimer's disease is an example. Systemic lupus erythematosus is another example, where they kind of have differential things that are weighed differently to make a diagnosis. So something that eventually we're going to have to incorporate. And a lot of the discussion hinged around, what should we do for the next round of the criteria? And then the other thing is, we change the criteria every certain years, right? That's kind of the model we've been using. But is there a different model that might work better where you change the criteria a little bit more on the go as data is produced? We heard some of that. So definitely, I think, just because you have a new set of diagnostic criteria doesn't mean you've solved the problems. You need to continue working on things and continue to evolve the way we make diagnosis.
Thanks for listening to this episode of the Neurology Live Mind Moments podcast. To support the show, be sure to rate, review, and subscribe wherever you listen to podcasts. And as always, for more neurology news and expert-driven content, visit neurologylive.com.